In the 20 or so years that I've been an oral surgeon, I've seen a lot of changes in the way that implant dentistry is practiced. I remember when we first started out way back in the mid-80s, implants were placed to support a full arch prosthesis, and really for nothing else. A couple years after that, we started experimenting with implants to replace a single tooth or a partially edentulous ridge. That seemed to work out pretty well, and a few more years elapsed before we started pushing the envelope as far as how soon we placed an implant after the tooth was taken out. Whereas initially, following Brandemark's protocol, we waited at least 6 months, we started placing implants in extraction sites maybe a month or two after the tooth was taken out. We call that delayed implant placement. We found that that really didn't make a whole lot of difference as far as the success rate. The implants still were quite successful. So of course that led to immediate implant placement, where the implant was placed in the extraction socket at the very same time the implant was placed. And we found that this helped preserve the bone a little bit better. You didn't get quite as much bone loss at the site when the implant went in right away, and that it really didn't significantly increase the infection rate or complication rate otherwise. The next evolution of this was when we started placing provisional restorations on the implants at the times that they were placed. And this was usually done for a single tooth implant or sometimes for a short span. And again, the success rate really was very minimally affected as long as strict protocol was followed. And we also had the benefit of improved soft tissue aesthetics, especially in the anterior region, when we placed a provisional restoration at the time that the implant was placed. CT scans have been used for at least a dozen years in order to treatment plan dental implants, and initially we used this just to measure the location of the mandibular nerve in cross-section and look at how much bone we had between the floor of the sinus and the alveolar ridge, and to look at the ridge width. And we would take our ruler and measure directly on the CT scan. In the early 1990s, software was developed that would take the information from the CT scan and allow us to do simulations of our surgery on the screen. And this was a big leap forward as far as being able to do treatment plans. One of the big limitations of this, though, was that it was very difficult to translate the treatment plan on the computer to actual surgery in the patient's mouth. So the next big revolution in implant dentistry was the ability to take this data on the computer and be able to translate that into a surgical guide that could be used for very accurately placing the implants in the precise spots, positions, and angulations where we had planned on the computer. And thus was born 3D guided surgery. In the last few years, cone beam CT scanners have gone from the university to private practice. They've become much more prevalent. There are a number of excellent machines on the market today, and so it's not uncommon for implant surgeons, whether they be periodontists, oral surgeons, or even GPs, to have a cone beam scanner in their office. And this has really revolutionized implant dentistry because you don't have to send the patient out to get them scanned anymore. The convenience of having a scanner in your office really is pretty tremendous. And a few years ago, I started using 3D guided surgery more and more in my implant practice, and then having added a cone beam CAT scanner to my office has really made a tremendous difference in the way that I do implant surgery now. Currently, probably about 85% of the implants I place are done using 3D guided surgery, and probably that percentage will increase as time goes on because, as you'll see, the benefits of 3D guided surgery are increased accuracy in implant placement because you know what the anatomy is in 3 dimensions, facilitated surgery because with a guided stent there's no guesswork at the time of surgery. A lot of times this means a less invasive procedure for the patient, which means less postoperative discomfort and more rapid healing for them. And because of the time that it saves in doing implant surgery, you're actually able to increase your daily production in the office because you can do more surgeries. And so I'm going to share with you a case from my private practice that really illustrates the power and the benefits of 3D guided implant surgery. The patient in this case is a relatively healthy 63-year-old woman who was referred to me by her general dentist for evaluation and treatment of tooth number 4. The tooth had endodontic treatment a number of years previously, and as you can see had a post-incornate crown and had recently become symptomatic with some tenderness and some swelling. As you can see on the radiograph, there is also widening of the periodontal ligament space on the mesial and distal of the root, as well as a small periapical radiolucency. So this is basically pathognomonic of a fractured tooth. So unfortunately for this lady, this tooth is going to have to come out. Her dentist very appropriately discussed with her her options for tooth replacement, and she opted to replace this tooth with a dental implant. She really wanted to avoid any kind of removable appliance at any point, and so she requested, if possible, that the implant be placed at the time of extraction, and that, if we could, also place a provisional restoration. Her dentist was happy to go along with this request, and so not only did he send her over with this radiograph and a referral slip, but also sent her over with a provisional crown that he'd made on her study model for us to place at surgery. So it was explained to her in quite a lot of detail that this is a tooth that had some signs of infection in the bone around the tooth, and that if we did an immediate implant, that there's a slightly higher risk of the implant failing, and she was willing to accept that risk. Now, a lot of times with a premolar, when you take the tooth out, the socket is the perfect spot in order to place the implant. So you just go right down the socket, prepare the site a little bit, and the implant goes in the same position and same orientation as the bicuspid root. So let's take a look and see if we can do this in this case. Normally with a premolar site, I'm going to use about a 4 millimeter diameter implant that's 13 millimeters in length. That seems to be kind of the average for this site. And if we take a look at a projection of where the implant is going to go, what we see here is that the root is angled so that it's much closer to tooth number 3 than it is to tooth number 5, and that with a 13 millimeter implant it would most likely penetrate the floor of the sinus, and so we'd have a perforation into the sinus cavity. So what we want to do is we want to actually redirect the location of the implant so that it's a little bit more to the mesial, a little bit more parallel with the adjacent teeth, and we see that that will put us in a little bit better bone so that we're not going to perforate in the sinus. We may engage the floor of the sinus, but that'll be fairly minimal. So we want to go ahead and place the implant in this new orientation, and if we're going to do this freehand, we're going to be doing this through the extraction socket. So if we're going to do this freehand, what we're going to do with our round burr and then our 2-0 twist is we're going to try to angle this implant in the correct orientation and position, and we're going to have to be really careful that as the burr contacts the mesial slope of the socket, that it doesn't deflect it posteriorly and the implant ends up staying right in the extraction socket and not where we really wanted it to go. Well, now that I'm getting into middle age, I want everything that I do in my practice to go as smoothly as possible and have as few complications and whoopses as I possibly can. And so that's one of the reasons I've really embraced guided implant surgery with open arms. So that's what we're going to do in this case, is we want to get this implant in just the right position so that it's right where we want to have it. And we want to be able to do that very accurately and very predictably. So in order to accomplish this, I took the provisional crown on the study model and used a 1.5 millimeter vacuform shell to create this template. And then we take the GALILEOS scanning bite plate and affix that to the vacuform shell using self-cure acrylic. So we place the scan template into the patient's mouth and then take him to our GALILEOS cone beam scanner in order to acquire our data. So the whole scan takes about 15 seconds, and about 3 minutes later we get the implant planning screen. So we're going to go to our area of interest here, which is number 4, and notice that the tooth is still there on the scan. We're able with the software to actually plan for immediate placement, and we're going to enlarge that area a little bit, kind of line everything up so we can see this area very clearly, and then we're going to go to the implant planning screen and go click on this little icon here. We're going to be placing the implant at number 4. It's going to be a replace select tapered groovy implant that is 4 millimeters diameter and 13 millimeters in length. Go ahead and click OK, and then we're going to go ahead and drag that implant and just plop it down right where we want the implant to reside, and then we can go ahead and adjust the angulation and place a little more precisely. You'll notice that there is, in addition to the outline of the implant, there is a 2 millimeter safety margin that's indicated around the implant, and that's used because you want to have at least 2 millimeters of space between the implant and the adjacent teeth, and of course you want to be at least 2 millimeters away from the nerve if you're doing a mandibular implant. So what I'm doing is I take the image of the implant and I superimpose it over the adjacent tooth that I want to be parallel to, and then move it back to the space. And that way I ensure that I'm going to be parallel to the adjacent teeth. Now we go to the implant align screen, and we can do some further tweaking to make sure that we have this implant aligned just the way we want it to be. There, I superimpose it over the adjacent tooth again just to make sure that we're going to be parallel. And we see that the center line of the implant goes right through the center of the crown as we want it to do. We add a projection of the final drill, which verifies that we are going to be centered nicely within the crown, although I'm going to do a little bit of fine-tuning here just to make sure that the position is as precise as we can get it to be. Now I'm going to scroll through the axial slices here and make sure that I've got my 2 millimeter clearance all along the length of the implant. And basically now we've planned the implant placement. This took all of about a minute and a half. And now we can print out a planning report, and this will go in the patient's chart. This shows an overview if you're doing multiple implants, as well as a detailed report for each individual implant. So in addition to putting a copy of this in the chart, I'll also send a copy of this to the patient's restoring dentist so that they have it for their records. And not only does it show the implant position, but it also shows the implant make and the implant size. Then we go to our implant ordering screen, where with just a couple of mouse clicks we're able to take the data from the implant planning and burn that into a CD, which is sent along with the study models and the radiographic template to Sirona in Germany, where the radiographic template is actually converted into the drilling template. And so here is the surgical template or drill guide, and the turnaround time for this is approximately 5 to 10 working days, and that's for it to be picked up in my office, FedEx to Germany, the drilling guide to be manufactured, and then returned back to my office. So the turnaround time is actually pretty good. So what I want to do in this case is I want to have a provisional restoration that is ready to go in at the time the implant is placed. And one of the great things about doing guided surgery is that before I've even done the surgery, I know exactly where that implant is going to be placed, and so that I can make this provisional ahead of time, and it'll go right in with minimal, if any, adjustment. So on the left you see the implant analog or implant replica, and the other two parts are used to attach this to the surgical guide in order to retrofit the analog back into the original study model, thus allowing you to fabricate a master model that will be used for designing the prosthesis. So here is this patient's original study model with an implant analog retrofitted back in, and then I'm going to use a Nobel replace immediate provisional abutment and secure that into the implant replica. I then took the provisional crown that the patient's dentist made, and I fitted that onto the coping that goes over the immediate provisional abutment, being sure that it was positioned so that it was completely out of occlusion when it was seated. And this is a critical factor when you're doing an immediate implant, is even though you may be doing immediate provisionalization, you have to make sure that there's no occlusal trauma to the implant, because that'll compromise the very delicate healing process and increase your failure rate. I then contoured and polished the cervical portion of the crown around the abutment to prepare it to be placed at the time of surgery. Okay, so now let's get to the surgery. So we're going to put a throat pack to pack off the posterior pharynx behind the tooth. We're making a sulcular incision, and you notice there on the facial aspect there is a small fistula from the infection that's been around this tooth. This has been symptomatic for probably a couple of weeks. We're going to go in with a spade elevator because we always like to do atraumatic or minimally invasive extractions whenever possible. So we're going to use our spade proximator on the buccal, mesiobuccal, distal buccal, and do some luxation with it. And you can see that this is mobilizing the crown and hopefully the root with it. So now we get our apical retention forceps, and we're going to seat it as far apically as we can on the tooth and luxate it to the palatal, to the buccal, a little bit of rotation at the same time. And we see that the tooth lifts out pretty easily with the forceps, and that there's a fair amount of granulation tissue that is adherent to the root, as well as the evidence of the prior apical surgery. So now, once we have gotten the tooth out, we want to get rid of all the any evidence of infection. And this, of course, is critical because we're going to be placing an immediate implant, and we want it to be successful. So, yeah, as I've mentioned many times before, I do pretty much everything using a fiber optic headlight and 2.5 power surgical loops. If you want to use higher loops, you can, but definitely I wouldn't use any lower. And so when I go in now, I'm using a spoon curette. This is a molt angled curette, and I'm going to get into the socket, and I'm going to thoroughly debride the socket as much as I possibly can. And my goal is to get rid of all soft tissue that I can see in the socket, see and feel, so that when I go in with a curette, I'm feeling good, healthy, solid bone all the way around the socket. If there's any granulation tissue at the apex, I'm going to remove that also. As you notice, I'm spending a fair amount of time doing this, and now I've switched to a straight double-ended molt curette, and I'm going to get back into the socket. Sometimes a straight curette gives you better leverage in order to really scrape those socket walls. The angle gives you sometimes better access, but the straight will give you better leverage. And so if you're going to be doing these kinds of things, you want to make sure that you have both straight and angled molt curettes in your arsenal of instruments. So now that I've loosened things up, I'm going to go in with my small mosquito hemostat and just take out any remnants of soft tissue, compress the bony plates, although they're pretty solid, so they're not going to move much. And now we're going to get ready for placing the implant. We also irrigated out the socket with lots of sterile saline. Now I'm going to try in the surgical template. This is a GALILEOS surgical template made off of our CT scan data. And this particular implant template or implant surgical guide is fitted with a Nobel guide diameter sleeve for a regular platform implant. So we're actually going to use a Nobel guide drilling set and place a Nobel replace select implant into this site using the surgical guide to help us with very accurate implant placement. So first we start with the 2-0 twist drill. You don't need to use the tissue punch because obviously there's no tissue there because the tooth was there. And we're going to drill this to 13 millimeters with, again, lots of irrigation. We're then going to go to the narrow platform or narrow diameter drill, 13 millimeters in length. I'm going to skip the 8 millimeter length because basically this is an extraction socket, and so 8 millimeter isn't even going to hit the walls. So I'm using here the sleeve and sleeve, the little guide sleeve that is going to allow the narrow platform drill to be used with high degree of accuracy in the regular platform drilling sleeve. So now we're going to come back with the regular platform diameter, which is a 4.3 millimeter diameter tapered twist drill. And we're going to go back for basically the last time, third drill with our osteotomy, and prepare this site. And we're going to use sort of an in and out motion, light pressure. So you can see it didn't take a whole lot of force because we're in the maxilla. The bone is not quite as dense. And now that we've got the osteotomy is drilled, we're going to take out the surgical template. Now, if you were drilling the implant into solid bone, you could leave the surgical guide in and you're going to place the implant right through it, but I like to take it out at this point so I can inspect the osteotomy site. And you can see that there is a small perforation in the floor of the sinus, but the membrane's intact, so we're going to inject some Grafton gel right into the site and then pack it down with the back end of my periosteal elevator. What this does is that's going to give a little puff of bone that's going to be pushed up by the implant into the sinus floor to give a little extra cushion there, and also it's going to fill the gap between the implant and the alveolar wall. So now we're going to put the surgical template back in the patient's mouth and put that back into position and stabilize it. So now we have the implant. It's a 13 millimeter long by 4.3 millimeter in diameter replace select tapered implant, and this is on the mounted guided surgery mount. And so that goes right through the surgical template, and we're going to drill it down. We set the drill at 35 Newton centimeters, it'll torque out at 35 Newton centimeters. And so the implant goes all the way down to, you can see where the sleeve becomes flush with the surgical guide, and then the drill basically stops. So now look like the implant's fully in place, and I'm going to line up the implant. Remember, the replace select implant or Nobel replace implant has an internal connection with 3 lobes, and you want to align the implant so that one of those 3 lobes is always pointing to the buccal. And there's little dots on the implant mount which indicate where these 3 lobes are located. So once we have the implant lined up and it's oriented correctly, we're going to go ahead and we're going to remove the implant mount. Just do that by hand with a unigrip driver, and then we can go ahead and take off the implant mount. Now sometimes the fit is so precise that it's very difficult to get these implant mounts off. So what I'm going to end up doing here is just taking the implant mount and the surgical guide out all in one piece, because I couldn't really separate them. It just doesn't want to move. So we're just going to, since we've backed off the screw, we're just going to take the surgical template and the abutment all out in one piece. Loosen the screw again. Hopefully that'll help. And sometimes it takes longer to get the mount off than it does to actually put the implant in. And a little bit of wiggling, a little bit of coaxing, a little bit of elbow grease, and the surgical template comes off. So now we'll take a look and see. You can see the implant in place. You see that it is oriented correctly with one of those lobes towards the facial. And the implant is perfectly positioned, approximately 2.5 millimeters below the gingival margin. So now we're going to take our Nobel Biocare immediate provisional abutment, and we're going to screw that down into place. And we're using 20 Newton centimeters of force. Here I'm just putting it in by hand, but then I'm going to come back with a torque wrench and tighten it down to 20 Newton centimeters. You want it to be tight, but you also want it to be removable later. And then I'm going to go back and use up the rest of the Grafton gel that I have and just sort of pack it around the implant and around the base of the abutment so that I have good bone in there. And since it's such a tight space, I'm going to use my perio probe to actually pack it in there. And I can use that to fill in around the implant. So compacted the bone down around the abutment, made sure that there is no bone on the abutment so that I can fully seat the provisional crown. And I've got a little bit of bone left, so you just have to use it, because if a little is good, more is better, right? Actually, sometimes the enemy of good is better. Next, I'm going to take a little slice of collar plug, and this is going to be about a 3 or 4 millimeter thick slice of collar plug. So I'm going to take that little piece here and cut it in half, and then I'm going to score it up the middle in a couple places, sort of a triangular scoring or Y-shaped scoring, so that I can use this and pack it over the bone, actually use that to hold the Grafton gel in place when I put the crown on. So this is going to act as sort of a barrier membrane. Now this is not a great barrier membrane like, say, Gore-Tex would be, but it works well enough for our purposes, and it fits in that space, and it's resorbable, so we don't have to worry about going back to ever take it out. So I'm going to put that into place, and again use my periodontal probe to pack it subgingivally and around the abutment. And sometimes it takes a little bit of teasing to get it in just the right spot. And there we go. Tissue looks pretty good. Remember, we did this with basically completely flaplessly and minimally invasive extraction. So now I'm going to come back and get my provisional crown, and of course you have to orient it the right way, buccal to the buccal rather than to the palatal, and we see that it goes right on with absolutely no adjustment at all. And notice that it is completely out of occlusion, just as we planned on the model. So that goes all the way down. And then we're going to take it off and then use some Temp-On, some temporary cement, in order to, just a very, very small amount applied with the perio probe again, so that we can cement this on We don't want it to come off, because if it gets loose, you have movement of the provisional crown, then that's going to irritate the tissues, and you'll get inflammation of the soft tissues around the implant, and that could eventually possibly lead to failure of the implant. So that's why we use the temporary cement, even though it fits so well, because we don't want to have any movement at all. So now let's go back and let's get our provisional crown. It's got a little bit of cement in it, just enough to hold it, not enough so that any extrudes out though, because it's really the retention of the coping that's going to hold this in place. And we press it down in place, and then make sure that it's fully seated, make sure that it's out of occlusion, and then of course have the patient bite down on a 2x2 gauze. Here we're verifying that it is completely out of occlusion. Looks good. You can see it's got very nice soft tissue contours, since we're going to have very nice soft tissue anatomy when this heals. And then have the patient bite down on the gauze, and we're done. Not a single suture is necessary, because we didn't lay a flap. Of course, there was a little bit of editing here, but the whole procedure took about 20 minutes altogether, and I was actually going a little bit slower than I normally would, just because of the fact that we were videotaping, and I wanted you to be able to see what I was doing. So here we have now, you can see on the upper left is the image of our treatment planning that was done on the GALILEOS implant software, showing where the implant intended to be placed, and just to the right of that, on the upper right, is a radiograph showing where the implant was in fact placed, and we can see that our implant placement was pretty darn accurate. And then on the lower left, you can see the provisional crown after it was made on the master model, and then on the lower right, actually in the patient's mouth. So this is a pretty fantastic service you can provide for your patients, and it's something that just was not possible prior to the development of CT guided surgery. And again, as I mentioned, the fact that we can have our cone beam scanner right in the office really facilitates this type of high quality treatment. As far as post-op instructions for this patient, was started on some Keflex, and I like to use the 750 milligram strength, because it's given twice a day. It's a lot easier for the patients to remember. So they started the day before and for 3 days after, so basically a total of 10. And also Paradex rinse twice per day starting the day before surgery and continued until the bottle is empty. Also, we give the patient a prescription for an analgesic. It really doesn't matter what you give them, Darvocet, Vicodin, because they're probably not going to need it. Probably Advil or Tylenol is all they're really going to need. I normally see the patients back for their first follow-up exam at 2 weeks, and then a month after that, and then at 4 months, at which point they are ready to send to their general dentist to have their definitive restoration.